Samaritan. Protect my energy from your bad aura. Now my pastor say I be my healer, everything I desire. I go receive my rhythm, flow like a river. If you get your walk, come on, go and sit down. I go just para, come on my jigger. I go just stay, follow my dreams. I'm feeling vibes on vibes, ticking dynamite. Know your candlelight, you know I'm just that type. No. Protect my energy from your bad aura. Now my pastor say I be my healer, everything I desire. I go receive my rhythm, flow like a river. If you get your walk, come on, go and sit down. I go just para, come on my jigger. I go just stay, follow my dreams. I'm feeling vibes on vibes, ticking dynamite. Know your candlelight, you know I'm just that type. No.
Good morning, everyone. Ms. Gwen, we can begin.
Good morning, everyone. The National Coalition of 100 Black Women Incorporated, the Pennsylvania chapter, is delighted that you are joining us today for our Heart Healthy conversation. We have dynamic panelists and testimonials who will talk about heart disease issues that plague our community. Special thanks to our sponsor, Mainline Health, Lankenau Heart Institute. We welcome you to engage in the conversation and ask questions in the chat box throughout the program. At the end of the presentation, there will be a Q&A. As a special edition, we are excited to have our Melanin Uncorked Wine Basket raffle. I'd like to share a few housekeeping items. All persons will be muted during the webinar. Please place your questions in the Q&A box. For those who did not get the opportunity to purchase a raffle for the wine basket, you still have until 10:45 to make your purchase in the chat. And now I present to you the president of the National Coalition of 100 Black Women, Inc., Pennsylvania chapter, Latifah K. Fields, who will welcome you and share more information about our organization. President Fields.
Thank you, Sister Gwen. Good morning, good morning, good morning. Please place good morning in the chat. Raise your hand. Be ready for a phenomenal day. You are in your own home, your own space, or you might even be on the side of the road, but we thank you wherever you are. As Sister Gwen stated, my name is Latifah K. Fields, and I'm the president for the National Coalition of 100 Black Women Incorporated, Pennsylvania chapter. The mission of the NC 100BW is to advocate, and as we like to say in Pennsylvania, unapologetically on behalf of Black women and girls to promote leadership development and gender equity in the areas of health, education, and economic empowerment. Across the US, we are comprised of over 3,500 members and over 60 chapters in 27 states, including the District of Columbia. The Pennsylvania chapter is the largest chapter with over 160 members, where our work focuses primarily in the Philadelphia region. Through our national and local partnerships, we are proud to be a voice for our communities. We invite you to learn more about our organization as well as the Pennsylvania chapter at www.nc100bw-pa.org. So we thank you again for attending today's program. We hope that you leave with additional knowledge on staying heart healthy. Special thanks to our health committee and fundraising committee for bringing this transformational programming and fundraising initiative. It may be a little early to grab your wine glass, but maybe have it prepared later as we find out whether or not having wine is really good for the heart. I want to thank our guest speakers and our testimonial givers for being our subject matter experts. We additionally thank our sponsor, Mainline Health, Lankenau Heart Institute. Thank you again so much, and I'll now turn the program back on over to our health committee.
Thank you, Madam President. Good morning, everyone. I am pleased to introduce our panelists for today's program. Our first two panelists are Dr. Renee Bullock-Palmer and Dr. Shafia Morrison. Dr. Renee Bullock-Palmer is a cardiologist and is board certified in cardiovascular disease, nuclear cardiology, adult congenital heart disease, cardiovascular computed tomography, and adult echocardiography. Dr. Bullock-Palmer earned her medical degree from the University of the West Indies, Faculty of Medical Sciences in Kingston, Jamaica. After medical school, she completed a residency in internal medicine and fellowship in cardiology at the SUNY Downstate Medical Center College of Medicine in Brooklyn, New York. She also completed a fellowship in advanced cardiac imaging at St. Luke's Roosevelt Hospital Center of Columbia University in New York. Dr. Bullock-Palmer's special interests include women's heart disease, cardiac amyloidosis, and cardiac imaging. She has participated in many clinical research projects and authored numerous articles in peer-reviewed medical journals. Dr. Shafia Morrison is a board-certified family nurse practitioner and educator since 2008. She completed her doctoral studies at Villanova University and advanced practice at LaSalle University. She has over 25 years in the field of medicine. Her private practice clinical experience has been in family practice and adult internal medicine. Currently, Dr. Morrison is employed at United Healthcare, Optum Health, as a lead advanced practice clinician, where she is a geriatrician and clinician for the institutional and community model of care. Dr. Morrison has taken ownership of her company's mission, helping people live healthier lives. She also believes in educating her patients to take care of their own health and seeking to understand what factors impact their health. Ladies, welcome. Thank you very much. And we will begin the program with Dr. Renee Bullock-Palmer.
Good morning, everyone. Can everyone see my slides and hear me? Okay. All right, so I'd like to first thank National Coalition of Black Women Pennsylvania chapter, including Rolanda Coverson and all the organizers of today's session for inviting me to give this talk at this very important event. So I'm actually director of the Women's Heart Center at the Boer Heart and Lung Center, and also I direct the cardiovascular imaging program there. And let's go. So as you know, February is Heart Awareness Month, and this is why today's event is so important. Heart disease is still the #1 killer of women in the United States. And despite this fact, it's commonly thought that heart disease is a man's problem when it's actually not. Cardiovascular disease mortality is actually increasing, especially in the younger age women, less than 55 years of age. And actually the cardiovascular mortality is greater in women in this age group compared to men. So there are common perceptions that cancer and other forms of other diseases are actually the greatest risk for women. However, the reality is that cardiovascular disease still remains the leading cause of death for women in this country and is actually twice the cause of death compared to cancer. And even among different ethnicities, particularly for our population, African-American women, you can see that cardiovascular disease is a leading cause of death in our own communities. So there are several myths versus facts. As I had mentioned, men are oftentimes perceived to be the likely recipients of heart disease and cause of death, when in fact, heart disease is just as likely a killer for women as it is for men. And cancer, as I mentioned, is often thought to be a common cause of death, when in actually reality, as I mentioned, cardiovascular disease is the leading cause. It's often thought that all doctors are aware of women's risk of heart disease and act accordingly, when in fact, there are several providers in our own communities that underappreciate the fact that heart disease is a leading cause of death for us women. And this may lead to undertreatment and underdiagnosis of heart disease in women. In our own unique state, Pennsylvania and New Jersey, the annual death rate for cardiovascular disease is 295 deaths per 100,000, which is quite high, and this therefore is an important problem. So 1 in 4 women actually will die of cardiovascular disease, and as of 2013, this accounts for over 280,000 women per year. And in fact, only 54% of women recognize that heart disease is their #1 killer. Among various ethnicities, Caucasians, African Americans, and Hispanics, you can see that in our own communities, African Americans and also Hispanics, that this is a major cause of concern. Now, almost 2/3 of women who die suddenly of heart disease will have no previous symptoms. So even if you're having no symptoms, you may still be at risk for heart disease due to the underlying risk factors such as diabetes, high blood pressure, and high cholesterol. Unfortunately, women are less likely to call 911 when they're having a heart attack. So it's very important that if you're having symptoms, or if you know of anyone with symptoms, if there is cause for real concern, that you should seek emergency care as soon as possible. So what is cardiovascular disease? So cardiovascular disease actually incorporates several diseases of the heart. This can range from a heart attack with myocardial infarction, where patients will come in, they'll have chest pain, other symptoms, and oftentimes that's due to a blocked artery, a blocked blood vessel in the heart. This may manifest with angina, chest pain, or discomfort due to decreased blood supply to the heart muscle. Stroke is also another form of cardiovascular disease, where patients may have a blocked vessel in the brain, and that can cause a stroke. High blood pressure is another form of heart disease. And oftentimes for patients, if they do not have their blocked artery opened, over time, the muscle or the heart can become weak, and this can manifest as heart failure. So as I had mentioned before, the heart is one of the most important organs in our body. That's really the engine of the body. It's made of various parts of which includes muscle, and that muscle, that tissue has to be supplied with blood flow. And the arteries are the blood vessels that provides blood flow to the squeezing heart. So as we go throughout our activities throughout the day, where the heart relies upon a healthy blood vessel to provide adequate blood flow to the muscle for us to function. Now, over time, if you do have heart disease, if there's increased cholesterol in the blood that can lead to plaques being formed within the vessel. And this is just showing that with our heart, normal, a healthy artery, blood vessel, there's no blockages. Over time, however, that plaques can form, and this plaque can eventually grow and occlude, block the blood vessel, leading to a heart attack and heart disease. So a buildup of plaque within the vessels, as I mentioned, decreases the blood flow. Over time, the blood flow can cause scarring and weaken the heart muscle, and that can lead to heart failure. And with heart failure, patients may have shortness of breath, they may have swollen legs, they may have issues where they're unable to lay flat because their lungs are filled with fluid. So some of the symptoms that can happen when you're having heart disease includes shortness of breath, where let's say you are able to walk to the end of your driveway to check your mail. If you find that all of a sudden or over time, you're unable to walk that distance because of overwhelming shortness of breath, that might be a sign of heart disease. Fatigue, where you're just feeling very tired. Malaise, where you just have no energy, that can also be a symptom. Now, chest pain is oftentimes perceived that women are not as likely to have chest pain, when in fact, women are just as likely as men to have chest pain. And I also oftentimes use the term chest discomfort, because patients sometimes perceive that, okay, I'm not having chest pain, but I'm having chest heaviness or chest tightness. That's actually a red flag for heart disease, because that's usually how heart disease presents, where feeling like a weight on the chest, feeling like an elephant is sitting on the chest. Symptoms tend to occur during activity or when you're emotionally stressed. That can be a sign. When men and women with heart disease may experience those symptoms, particularly if women have diabetes, especially over a long period of time, they may not have any symptoms. And that's why sometimes you really have to delve into getting a good history, having a real conversation with your patients to really make sure that you're not overlooking a problem. So the AHA, the American Heart Association, actually had released guidelines on the management and diagnosis of chest pain. I was fortunate to be a part of the writing group of this very important document. And just some important points to highlight in that is that, as I had mentioned, women are just as likely as men to have chest pain. Women and anyone presenting with chest pain should seek early care if they're having acute symptoms, to decrease the risk of having damage to the muscle of the heart. It's very important to have shared decision-making with your physician or your provider to make sure that you understand the risks of not getting treated or tested, and also the risk of certain tests, and if you're really the right person for that particular test in your situation. So it's very important to have a conversation with your physician, and you really have to advocate for yourself if you're not having any answers to your problems. So prevention is key. Primary prevention, preventing your first heart attack, preventing your first stroke. And for those who unfortunately may have had heart disease, is preventing another heart attack or another stroke. Because if you yourself or anyone has had a heart attack or a stroke, you are at very increased risk of having another one. So it's very important to prevent these issues. So how can we prevent disease? One of the most important things is to lower your risk, getting your sugar, glucose under control, your cholesterol under control, your blood pressure checked and controlled as well if needed, and to also see and follow up with your physician regularly for your routine checks, and also if you're having symptoms, to get treated and tested. Healthy lifestyle changes are also important, and particularly for women with diabetes, the risk of heart disease is very high. And it's very important that you not only control your glucose, but also your cholesterol and your blood pressure, because unfortunately, in this population, women with diabetes, the risk of heart disease is at least 3 times higher than other patients. So lifestyle changes, having a low-fat diet, having a diet that's rich in fruits and vegetables and high fiber, and maintaining a healthy weight to try to lower your risk. Exercise is very important, having a moderate amount of physical activity throughout the day to decrease your risk. This also has benefits not only for heart disease and for your blood pressure, but also for your mental health as well. And quitting smoking. Smoking is the number one risk factor that can definitely lower your risk if you quit smoking. So it's very important to consider that as well. For secondary prevention, if you've had a history of heart disease or stroke, make sure that you see a cardiologist, or in cases of a stroke, a neurologist on a regular basis to take your medications as prescribed. If you're having problems with a particular medication, very important to seek guidance from your provider, from your physician, have a conversation and see if there are alternative choices to your medications rather than just stopping the medication without any medical guidance. So increased risk factor burden, as I had mentioned, high blood pressure, diabetes, obesity, cholesterol, smoking, a sedentary lifestyle, all increases our risk for heart disease. And a lot of the risk of heart disease are modifiable, as I had mentioned, lifestyle changes, because that can decrease the risk of all of these risk factors, including diabetes, high blood pressure, high cholesterol, obesity, smoking, and physical inactivity. Unfortunately, for some who may have a strong family history of heart disease, if you've had a family member, a first-degree relative, be it a parent or a sibling who has had a heart attack, for women younger than the age of 65 years of age, for men younger than the age of 55 years, and you are at increased risk for heart disease, and you should definitely get your risk factors under control. So the American Heart Association has the Life Simple Sevens, and this includes, as I had mentioned, a healthy diet, healthy glucose levels, managing your cholesterol, your blood pressure, quitting smoking, exercising, and maintaining a healthy weight. So just a little bit on metabolic syndrome. So this is actually a syndrome that incorporates many of the risk factors that I mentioned: obesity, having an increased waist circumference, having high cholesterol, such as triglycerides, which is another form of cholesterol, having a low HDL. So HDL is a good cholesterol, and that's what you want to keep as a higher level. If you have a lower level of this, then that's also under the umbrella of metabolic syndrome. Maintaining a healthy blood pressure for those who have a high blood pressure and an elevated fasting glucose. So any of these three, any three of these 5 components, if you have any of these 3, then that's the definition of metabolic syndrome. And why is this important? So metabolic syndrome actually increases the risk for numerous other diseases, not just hypertension, heart disease, but also insulin resistance, which is diabetes, high cholesterol, type 2 diabetes, polycystic ovarian syndrome for women. This can also increase risk of infertility, dementia, certain types of cancer, such as breast cancer and uterine cancer, and a fatty liver. So this metabolic syndrome is a very important syndrome to try to avoid, to decrease the risk of these diseases. So what can you do? So one of the most important things is, one, getting educated, which is why this session is so important, for your own unique situation, knowing your own numbers, your cholesterol, your blood pressure, your glucose, your body mass index, which is a marker for obesity, and having these numbers checked. So there's something called a well woman's visit, which I fully endorse, that any woman over the age of 40, even if you're not having symptoms, should at least have a well woman's visit with either your primary care doctor or your cardiologist to get these numbers checked at least once or every 2 years. And that's even if you're not having symptoms, because sometimes you may go along your daily lives not knowing that you are having a lot of these risk factor burdens, and then it may manifest later on as heart disease. So one of the 10 things, as I mentioned, knowing your family history is important, whether or not you have a history of premature heart disease, adopting healthy habits, tobacco cessation, minimizing alcohol use, maintaining a healthy weight, getting enough sleep, and managing stress, knowing your heart-related risk, as I had mentioned, getting your numbers checked. Now, taking medications, as I had mentioned, very important, and to have a discussion if you're having issues with your medications. Regular visits with your physician is very important, and coordinating your care with your provider, because remember, it's very important to have a very good relationship with your physician so that they can understand your questions, your needs, and that your needs are being addressed with the physical, with the physician visit. Revising your diet, not just a diet that's high in fruits and vegetables, but also minimizing your intake of red meat, trying to minimize your intake of high fructose corn syrup, which is very dangerous in terms of increasing risk for diabetes and high cholesterol. Trying to avoid chips, fries, those are types of unhealthy meals. Maintaining a healthy weight through diet and exercise, and setting goals for exercise. So at least 150 minutes of exercise per week is endorsed by the American Heart Association. So at least 3 hours of exercise throughout the week, spaced out And this can be varying from just simply walking. You might also tracking your steps with a pedometer or on your phone is important, with at least 10,000 steps a day. And the benefits of physical activity extend beyond heart disease. It can also improve, as I mentioned, mental health. It can decrease your risk of certain cancers, strengthens your bones and muscles, decreases the risk of osteoporosis, and actually has been shown to increase the chances of living longer and promotes a healthy sleeping habits as well. Weight loss, very important for those who are overweight or obese. And there, for weight loss, you should be at least getting 4 hours of exercise throughout the week if that's your goal. Stress management is very important. So oftentimes you cannot control stress, but you can control how you react to stress. And it's very important to do that as well, especially under current the situation that we're in with the pandemic. And just the last 2 slides on the pandemic. So the reason why it's so important for us to maintain a healthy weight is that, unfortunately, over the last 2 years, the pandemic has led to a drop in life expectancy. And this is particularly for us in our own community, for African Americans. There's actually been a loss of almost 3 years of the average life expectancy. There are various reasons for that. Many of us have not had or regular physical medical visits. We've been ignoring some of the screening tests that we should be getting. And also, sometimes, as I had mentioned, the pandemic has taken its toll on our own community. So the ways to really treat and to avoid all of this is to make sure that you get yourself vaccinated, getting your booster shot to minimize the risk of COVID-19 as well. Getting your regular visits. If you've missed any visits, try to catch up with your medical visits and your routine checkups. So just the top 10 take-home points before I finish. So heart disease is still the #1 killer for women in the United States. There's increased risk factor burden for young women. Decreasing the risk of heart disease is important. So knowing your risk, getting checked, and controlling your risk factors. COVID-19 has had an extensive impact on the body beyond the lungs. So it also affects the heart. So very important to get yourself vaccinated. Taking care of your heart, knowing your numbers. And if you have symptoms, making sure to see a doctor, do not delay care. And finally, COVID-19 vaccines are safe, and it's the best way to stop this pandemic. And for more resources, you may visit the American Heart Association, heart.org website, Centers of Disease Control, and the American College of Cardiology. And at our own institution, thebor.org, you can visit to get some very important information. And I thank you very much for your attention.
Thank you, Dr. Bullock-Palmer, for this wonderful information. And now, Dr. Morrison, you have the floor.
Good morning. Good morning. Thank you so much, Dr. Bullock-Palmer, and thank you to the National Coalition of 100 Black Women for this opportunity this morning. I'm a native Philadelphian as well, so I do miss home, but not in the wintertime. I want to share this quote to begin with by Thomas Edison. "The doctor of the future will give no medicine, but will interest his or her patients in the care of human frame, in diet, and the cause of prevention of disease." In the primary care setting, our #1 goal is health promotion and disease prevention. First slide, please, Dr. Coverson. The ABCs of the H&P. So the H&P is the history and physical that is provided. It's a conversation, an interview, a very intimate setting between a provider and their patient. And when I think about this, this word cloud, it's really important to understand that we have a unique role as providers as we are providing care and trying to gather information to best meet the needs of our patients in the community. The history and physical allows for a very special connection between the provider and the patient. It is a compassionate time. It is a time of reflection and empathy. It's a time of great listening and understanding, and really trying to connect to our patients to meet the needs that they may have coming in. We master listening with our eyes, watching body language, we're listening, and gestures, facial expressions. We're listening to the words that are not spoken when we are interacting during our patient interview. Next slide, please. When I think about prevention, Dr. Bullock really covered it intently. But when I think about the ABCs and assessing risk for heart disease or arteriosclerotic cardiovascular disease or cardiovascular disease, you'll hear that terminology interchange in the patient care setting. The ABCs, A is assessing risk. You know, understanding that primary prevention for those with uncontrolled things that you cannot control as far as your risk factors, like family history, like age and gender, women greater than the age of 55, 55, and decrease in estrogen levels. So if you are perimenopausal or postmenopausal, or even if you endured menopause at an early age based on your surgical history, if you've had an early hysterectomy, you may have lower estrogen levels. So that will put you at an uncontrolled risk. The B in the ABCs is maintaining your blood pressure. And Dr. Bullock did this very well when she talked about our numbers. And knowing our numbers is so important. A goal and a target blood pressure amongst us is 130 for the top number and 80 on the bottom. So 130 over 80 is a target. C would be assessing your risk, making it really personal to understand and know your family history so that when you're going to see your provider and they ask the question, do you have a family history of heart disease or hypertension or high blood pressures or strokes at an early age in your family, a maternal or paternal grandfather or a mother, someone that had a silent heart attack? These are the questions that we ask on a regular basis. So C is really assessing cardiovascular risk, family history, smoking. Smoking is the other C in the ABCs of the H&P. Cigarettes. Cigarette smoking decreases or increases your chance of heart disease, heart attack, high blood pressure astronomically. The D in the ABCs is diet, healthy eating, maintaining a healthy weight, and understanding what that means when you introduce fried foods, fatty foods that are in overabundance into your lifestyle. We have to emphasize the need for fruits and vegetables and, you know, really trying to balance our diet with the things that help promote healthy hearts. Another D is diabetes. Dr. Bullock shared about this, controlling with diet and exercise for type 2, knowing our numbers, knowing our hemoglobin A1C, seeing your primary care provider. And I do agree, once a year, you should be taking note of your numbers, your blood pressure, your cholesterol number, and your glucose, your fasting glucose levels. The E would be exercise, 150 minutes per week. That's about 30 minutes, 5 times a week of some type of physical activity to really decrease your chances of cardiovascular disease. There are controllable risk factors, smoking, sedentary lifestyle, I talked about that, limiting your alcohol intake. They say 1 glass of wine is probably the limit now. You know, there's new research coming out all the time, but we have to do what we can to control our risk factors. Primary prevention that's where we want to go. We provide people with knowledge and education before the onset of disease itself. This is before. Prevention is cost effective. It is the best way of ensuring the health of our communities and preventing diseases to occur in the first place. That includes routine doctor's visits. Secondary prevention is an early form of disease identification and treatment. So you need to take your medicines and, you know, modifying your lifestyle choices, making sure that you are seeing your doctor and getting your refills in time. This is another question that we talk about. I have my patients bring all of their medications to the visit because I want to see and make sure that they're taking them, that the dates are not 5 years ago. on the bottles. And we have a system where we are working together to ensure building a healthier community. Tertiary prevention is slightly different from the first two categories, and it involves reducing the long-term effects by helping patients manage their conditions and their chronic symptoms. The goal in tertiary care is to achieve and improve quality of life, and try to lengthen it over your life expectancy by preventing further complications. Very important. Next slide, please, Dr. Coverson. Thank you. Know your numbers. When I think about the picture on the left here, I likened it to a straw when you're having your favorite milkshakes. Milkshakes are okay, but in moderation, of course. But when we drink our milkshakes through a straw and it's really thick, like the ones from Chick-fil-A sometimes, you may not be able to get it through that straw. And it's the same things with clogging our arteries and increasing our cholesterol. The fats, the fatty substances in the fried foods, they get stuck in our arteries, and it makes it very hard for the blood to flow through our arteries. So that is where we have to understand the foods in our regular diets clog our arteries sometimes, and it's very difficult for the blood to flow through, which increases your chances of high blood pressure. Smoking narrows the arteries as well. That increases our chances of having hypertension and high blood pressure. So it's really important to know our numbers, to know that LDL, which is the bad cholesterol, should be between 0 and 99. This is information that I give to my patients, that our total cholesterol number should be less than 200. So we go over these things, that our triglycerides should be no more than 150. It's really important to know these numbers and decrease our risk so that we can be around and that we can help other people live healthier lives. Heart disease is like an iceberg. As the Titanic sailed along, only the tip of the iceberg appeared above the water. The captain did not see all the points of the ice underneath. With diabetes, risk factors of heart disease peak out at different times. For some people with high blood pressure, it's the first sign of danger. However, for others, high cholesterol suggests an impending collision. So like the captain scanning the water, it is extremely important for people with diabetes to routinely monitor for hidden risk factors of heart disease. I thank you for your time and attention.
Thank you, Dr. Morrison, for that wonderful information. We do have one question in the chat. So it could be probably for Dr. Bullock Palmer. I like drinking green tea spiked with turmeric and cinnamon tea. Do you recommend taking the cardiology predictor test as a preventive measure?
Absolutely. So there's actually a tool that's endorsed by the American Heart Association and the ACC that incorporates your blood pressure, ethnicity, cholesterol, smoking history, and that can actually calculate your risk of having a heart attack or stroke in the next 10 years. Generally speaking, a risk factor of less than 7.5% is considered low. Ideally, it should be less than 5%. Now, with regards to the second part of the question, what was that question? Part of the second question about turmeric.
Turmeric. Yeah, she drinks tea with turmeric and cinnamon tea.
Right. So turmeric and cinnamon tea. Actually, that's not harmful to the heart. I know some cultures that actually endorses use of turmeric and cinnamon to decrease your risk of high blood pressure. But although I do, have no issues with that, I think very important that you do not replace the medications that you're taking that your physician has prescribed with those alternative treatments. That's something that you can use along with your medications if you're supposed to be on your medications. Because I found that some patients may opt to, say, I'm not going to take the medications the physician prescribed, but I'm going to take turmeric and cinnamon. And, that should not be done. I mean, you should have a conversation with your physician, but those supplements do not cause any damage to the heart.
Okay, I see no other questions in the Q&A. So I thank you both, Dr. Bullock Palmer and Dr. Morrison, for the wonderful information that you provided for us this morning. Thank you so much.
Thank you. And if there are any questions after this, you can feel free to email me, but I'm going to be leaving. But enjoy the rest of the session. Thank you for the invitation.
Okay, thank you. And again, we will have another Q&A session at the end of the program. Okay. Next, we will have testimonials by two wonderful women, Ms. Myra Edwards and also Ms. Denise Smith. But we will start with Ms. Myra Edwards, who will share her story on how she's living with heart disease. Thank you, Ms. Myra.
Thank you. Hello, my name is Myra, and I appreciate you giving me this opportunity to share with you my testimony with heart disease. My journey with heart disease has been approximately 9 years. And I hope that what I say to you today will help you and give others the opportunity to be knowledgeable of heart disease, especially in African-American women. My journey started in March of 2013. After a regular day at work as a director of nursing, I encountered what I believe were flu-like symptoms. I had experienced nausea and I was nauseous and just achy. I did not feel well, but there was nothing particularly wrong. I telephoned my sister and I let her know that I just wasn't feeling great. And she said, go to the hospital. And I would dare not go to the hospital for what I thought was the flu. So I tried to wait it out, and within 15 minutes, I knew that that wasn't a good idea. And so I telephoned her again. And at that point, she had already had her husband, my brother-in-law, at my home waiting to take me to the hospital. And that was a bad step. I know now, and I would recommend to anyone, if you're feeling totally unlike yourself, if you know something is wrong, even when you can't put a finger on it, to make sure that you activate 911 and get medical attention immediately. My presentation to the emergency room was one that I thought was pretty typical, but I learned was very atypical for clinicians. As an African-American woman, I presented to the emergency room with symptoms of nausea, anxiety, and a sense of doom and pain in my arms that I would describe as tingling. The emergency room staff did not seem as alarmed as I was about my symptomatology. The ER staff who encountered me asked me to wait in the waiting room and to have a seat. And I said on numerous occasions, if I sit, I would die. And I felt that that's what would occur. But at this point, there was no inkling in my mind that I may be experiencing or having a myocardial infarction, heart attack, or any of those things. But during my wait, I began to have jaw pain on my right side. And I informed the receptionist of this information. And I said to her, well, listen, I think I may be having an MI. And although I think I should have been alarmed or afraid or shocked by what I was even saying, it was just so real that I may be having an MI. And I asked for aspirin, and they told me that I would have to wait. So I waited until I was in the triage area, and I explained to the young lady my symptoms of over the last 2 hours because it was that abrupt in onset. At that point, she instructed me to walk to the back of the emergency room, where she then did an EKG. At that point, as I remember, everything became fast moving and swift. She alerted the staff that I was having a STEMI, and that is an ST elevated MI, or just a type of heart attack that I'm sure the physicians can speak on, more effectively than what I can. But they told me that I would have to be transferred either by helicopter or by ambulance to a cardiac cath center, and I was a cath alert or a STEMI alert to a local hospital. I received awesome, meticulous care, and I recovered. And I'm here to say that although I have never to this day experienced chest pain, I had an MI that blocked 100% one of my coronary arteries, and I have at this time 2 stents placed. So I don't have the time to really share with you all of my wants, wishes, and desires about how important it is for women, especially African-American women or women of color, to always be aware of what they're feeling. There were so many clinicians and colleagues of mine who asked, how did you know? How did you know what was happening? You shouldn't be here. The physician who took care of me, said those words that no one ever wants to hear. You're having a massive MI and we're losing her, to my family. And that I never want anyone's family to hear. I was able to stay only 4 days in the intensive care unit, and I still follow, of course, to this day with my cardiologist at Mainline. Yay. Thank you. And if you have any questions, please let me know.
Thank you so much, Ms. Myra, for that wonderful testimonial. And I'm so glad that you're thriving and doing well.
Thank you.
All right, you're welcome. We will now have our next 2 presenters, Dr. Maribel Hernandez and Dr. Janet Dunn-Roman. Dr. Maribel Hernandez is a cardiologist in Wynwood, Pennsylvania, and is affiliated with Mainline Health Lankenau Medical Center. She received her medical degree from Stanford University School of Medicine and has been in practice for more than 20 years. Her medical training has included Stanford University Medical School, Harvard Medical and New England Deaconess Hospital residency. She also completed fellowships at Lankenau Hospital and the Medical College of Pennsylvania. She currently is the medical director of the Women's Heart Initiative at Lankenau Heart Institute. Dr. Roman's life's work involves improving outcomes for heart failure patients and promoting the use of palliative care and hospice. Dr. Roman is currently serving as the Director of Cardiac Services at Empath Health and has dedicated a large portion of her nursing practice to those suffering with heart failure. As a board-certified acute care nurse practitioner, certified heart failure nurse, and advanced certified hospice palliative care nurse. She has been the principal investigator in a plethora of studies to advance the use of palliative care in the heart failure population. Other research interests includes heart failure across the continuum, the reduction of symptom burden through comprehensive heart failure care, improving self-care through remote patient monitoring and simulation education. Dr. Roman's clinical experience expands across many concentrations, including cardiothoracic surgery, mechanical circulatory support, cardiac transplant, cardiac, medical, and surgical intensive care, emergency medicine, home care, and hospice. She is well published and has presented many podium presentations. Thank you, ladies. And we will start with Dr. Maribel Hernandez.
Good morning, and thank you for inviting me to join you today. Actually, my primary specialty is cardiac electrophysiology, which is a specialty that focuses in the electrical system of the heart. I'm board certified in both cardiovascular disease and subspecialty of cardiac electrophysiology. I want to share my slides now. I hope that you can all see them. So basically, most people are aware that the heart has the coronary arteries, valves, heart muscle, aorta. However, the heart has a full electrical system These are specialized nerve fibers that the heart requires to be able to activate the heart and pump the heart. It's like having a beautiful, perfect new computer, but no power. So without a functional electrical system, your heart won't beat, the heart will stop or malfunction, even if your heart is completely normal. In the bottom of this a picture, you can see when we go to a heart doctor and they check your electrocardiogram or EKG, this is a normal recording at the bottom. The small signal represents the top chambers, which is the atrium, and the larger spike represents the electrical activation of the bottom chambers ventricles, which is a larger mass, therefore a larger signal. So I was asked to discuss palpitations and arrhythmia as my specialty. And I just want you to realize that we all can have palpitations. And that's, most people feel like a fluttering or a skip beat or some sudden strum pulsation. And those are benign, and having that occasionally is normal. I have them on and off, and I don't worry too much about them because I know they're normal, but I know it can be very bothersome and make people anxious. But I just want you to know that having brief occasional extra beats is normal. However, there are several types of rhythms that definitely need evaluation. And the ones that are most common and benign are those early beats from the top chamber or from the bottom chamber. There's some sustained rhythms from the top chamber called atrial arrhythmias and supraventricular tachycardia. Tachycardia means fast heart rhythm, bradycardia means slow. And this is a rhythm strip of these extra beats that you can see, especially in the bottom electrocardiogram. You see a narrow, thin signal. This is normal, and then this larger signal. This larger signal is extra beats from the bottom chamber of the heart. And as I mentioned, those are benign, but can be really bothersome. This is a diagram of the different types of rhythms that you can have. These are more involving the top chamber, and they're the one on the top right side called atrial fibrillation. I'm gonna spend some time with that rhythm. On the right side top, one called AV node reentry. That's much more common in women, especially younger women. So they're depending on the site of the electrical system, you might have different manifestations. This is an electrocardiogram of the one I mentioned is more common in women. It is a very regular, fast, sustained rhythm. It can last minutes or hours. And this rhythm definitely needs treatment with medication, but right now the indication is actually the first line of treatment. You should be aware is not medication for this specific rhythm. It's actually a procedure called catheter ablation, where catheters are inserted into the heart and you find the electrical spot that's causing the problem and cauterize it. And this arrhythmia can actually be cured. So it's important to be able to get a diagnosis. This rhythm is more, fortunately, it's not as common. It's ventricular tachycardia. It's the kind of dangerous rhythm from the bottom chamber of the heart that causes sudden death or cardiac arrest. When you hear someone dying suddenly or collapsing suddenly and the only way to stop this rhythm is with the paddles, with shocking the heart. That's why it's important anybody collapses to call 911 immediately and start CPR, because if it's this rhythm, while the paramedics come, you can save their lives. This rhythm is actually more common in people who had already heart damage, heart failure, heart attacks. It's uncommon if you never had a heart attack or have a significant heart disease. So it's very important, especially with women, to do not guess about what you're feeling. If you're having episodes of these fast rhythms or irregular rhythms that are come and go, especially if they last minutes or definitely if they last an hour, but that if it's minutes, if it keeps happening, you need to be evaluated. And I say, do not guess, because a lot of women especially, they immediately attribute it to stress, anxiety, panic attack, and also unfortunately the physicians. I have seen many patients in my practice over the years that are being treated with medications for anxiety when they actually have an arrhythmia. So do not guess and get evaluated. And when should you actually go to the doctor? If you have these fast pounding or these sensations, as I mentioned, prolonged fast pounding, regular or irregular, especially if they're associated with dizziness, shortness of breath, chest pressure, severe fatigue, women know when there's something not right and you need to get evaluated. And again, I want to stress that you need a diagnosis. Do not let anybody treat you until you're fully evaluated and assume it's your stress or panic attack. We fortunately in the past, fortunately now we have much better tools than in the past. Because the problem with these rhythms, the challenge is that it's intermittent. And you might have a horrible episode lasting a few minutes or an hour at home. You go to the emergency room and you're perfectly fine and they send you home. In the past, we didn't have good tools to diagnose. So now we have several methods. We have monitors that last longer. You can wear them. In the past, we only had monitors that lasted for 24 hours. It usually was the 24 hours when you didn't have the problem. So I found that honestly, with the new technology, not as helpful, but we have monitors that you can wear longer, sometimes for 2 weeks, 1 week, depending on the frequency. We have now, this is one of the apps that I recommend my patients to get diagnosed. I have so many patients that have recorded their rhythm and we're treating them. So this is an app called it's called Kardia. You download the app in either iPhone or Android, and then you order a little strip, and you put usually from Amazon, and it costs only around $99, $100, but it has been extremely helpful in capturing these intermittent rhythms and women be diagnosed that could not be diagnosed in the past and get treatment. Another tool that a lot of people are using, if you have an Apple Watch, there's an app, the newer Apple Watch, that you can actually record the rhythm. And I see many patients in the office that they catch their arrhythmia and they're able to save it, email it, print it, and we are treating them. Some of them many need medication. Some of them actually need procedures to eliminate the problem. This is another tool that you need to be aware in terms of technology, where we have patients, they have symptoms, they faint, or they have very bad rhythms, but it happens like every 6 months. So it's very hard to detect, or they're unconscious and they're not able to use one of the tools that I just mentioned. This is inserted under the skin in the left side of the chest. Again, it's under the skin, not inside the body. And you get a home monitor with wireless connection, and it automatically records rhythms and has a 3-year battery. And I mention this because do not let any physician tell you that they're gonna treat you without knowing what the problem is. We have tools, and you need to be diagnosed. I don't have much time to go on our treatment, but you need to know that you can be treated with. Sometimes for the premature beats or elderly beats, when you have sporadically, if it's benign, honestly, I don't like to give medications unless it's really necessary. But for all these other rhythms that are more sustained, you need either medication or a procedure that I mentioned, ablation, which can actually eliminate permanently the arrhythmia. I want to move forward to talk about atrial fibrillation, which is one of the rhythms I showed. And atrial fibrillation is a rhythm that is an abnormal, a chaotic rhythm from the top chamber of the heart. It originates in the atrium. And as you can see on the left side of the image, you see this is a normal activation starting on the top atrium, going down the electrical fibers in an organized manner. And the EKG below that, it says normal sinus rhythm, is an organized rhythm. Atrial fibrillation is an abnormal electrical rhythm from the top chambers of the heart, and it's an irregular rhythm. And the way you know you have this rhythm is because it feels fast, or this irregular pounding is not very regular like the other rhythms. People describe it like having butterflies in the chest or fluttering all over the chest. The problem with this rhythm is that we have a spectrum, and this is the electrocardiogram, which as you can see is kind of irregular and not a regular pattern. The problem with this rhythm is that it presents in a wide spectrum. We have patients that show up in the office in the rhythm and they have no idea. And then we have other patients that present with heart failure, shortness of breath, very symptomatic, and other people present with intermittent palpitations. The reason I want to focus on this rhythm is that if you have this rhythm, you're at 5 times higher risk of stroke. And the reason is that when the electrical fibers are chaotic and irregular, the atrium cannot pump blood effectively, and little clots form. And inside the atrium, the top chamber, which can be, when the heart beats, it can be sent up to the aorta, up to the brain, and causes stroke. So this is a preventable cause of stroke. And as you know, stroke is the number 5 cause of death in the United States, and in women, and specifically Black women, is actually the 3rd cause of death. And not only death, is disability, which we all know that terrible disability caused by stroke. The point is that this is preventable if you are diagnosed on time. And 2.7 million Americans have atrial fibrillation, and it is estimated by 2025, up to close to 25 million people will have atrial fibrillation, and is the cause of strokes in 50 to 20% of patients who have a stroke. So what we are doing now, you need to be aware, is that if someone comes to the hospital with a stroke and they have risk factors to have atrial fibrillation, we actually insert that little monitor under the skin to try to see if they're having atrial fibrillation, because we can treat it with anticoagulants and prevent future stroke. And you probably are familiar, I want to review the signs and symptoms of stroke. So you can see in this image from the heart, little red clots traveling up to the brain. And the symptoms can be trouble with vision, troubles with speech, confusion, sudden weakness of face, arm, or leg. It's interesting that there is a study that showed that Blacks were approximately 1/3 less likely than whites to be aware when they have atrial fibrillation. And that's why it's important that you know if you have risk for atrial fibrillation. It's usually a rhythm that is more common over age 65, where we're seeing younger patients, primarily, I think, due to the obesity epidemic and the increase in diabetes and hypertension, all combined with the obesity epidemic. We're seeing people in their 30s and 40s and 50s presenting with this rhythm. So you need to, when you go to your primary care physician, remember that's why it's important to be checked and know your numbers and find out whether you are maybe at risk for this rhythm, especially if you're 65 years old or older. Again, possible risk factors include advanced age greater than 65, but not limited to that, or having already a heart attack, heart failure, hypertension, diabetes. Alcohol can trigger this rhythm, smoking, obesity. Sleep apnea is something that we look for in people who have this rhythm, problems with the valves. And so again, discussing this with your primary care physician is important. I want to review the symptoms again for atrial fibrillation and arrhythmias. Fast heart rhythm, fluttering, thumping, feels like a skip beat sometimes, shortness of breath, fatigue, sweating, chest pain. All of these you need to be evaluated. And call 911 if you think you may having, if you're having a sustained episode that is not stopping with symptoms, just go to the emergency room and be diagnosed. And women tend to have become, with this rhythm, tend to be more symptomatic and have a higher risk of stroke as a complication as compared to men. Therefore, one of the female sex was included as one of the independent risk factors for stroke, again, usually older women. And the goal of treatment is anticoagulation and to improve symptoms of life. And I want to mention that in the past, the anticoagulant that was used is warfarin or Coumadin, but now with the new anticoagulants are found to be superior. And as to warfarin, and aspirin and Plavix are not effective for prevention of stroke or clots from this rhythm. This is an image of what I mentioned, this procedure called ablation, where catheters are inserted into the heart. And it could be for atrial fibrillation and other rhythms where the rhythm can be identified and fixed. Not everybody's a candidate for this procedure, but I want to mention it as an option, that you have this option if medications are not working, because in general, women and women of color are not being offered this procedure as often as should be. In summary, for the palpitations are common and more benign. There are different types of arrhythmias. Get evaluated if you have prolonged symptoms of palpitations. Atrial fibrillation is a common arrhythmia associated with strokes. Strokes from atrial fibrillation can be prevented with anticoagulation. I was asked to talk also about signs and symptoms of heart disease, but Dr. Bullock Palmer did an excellent job covering that. I just want to point out a few things, add to her presentation, and specifically to remind that Black women face a greater risk of developing high blood pressure, stroke, and complications during and after pregnancy. And cardiovascular disease, the leading cause of maternal death in the United States. And a lot of, especially in the Philadelphia area, the maternal deaths, unfortunately, affects a higher proportion is Black women and due to cardiovascular disease. I'm gonna move forward. This was already covered, the symptoms, but I want to emphasize this, women, and I will finish here. women have unique risk factors in addition to the traditional risk factors. Early menopause or surgical menopause was already mentioned. Having hypertension or gestational diabetes or preeclampsia in pregnancy makes you a higher risk for heart disease. And the reason is pregnancy is like a stress test to the heart. It's a stress test to the vascular system. If you develop preeclampsia, hypertension, gestational diabetes, that's an indication that you're a high risk for development of problems in the next 10 years. So we are now have a program in my health system and other health systems that these women, even though everything resolves at pregnancy, they need to be seen by a primary care or a cardiologist within the next few months to establish long-term preventive follow-up. Autoimmune diseases like rheumatoid arthritis, psoriasis are risk factor. Women who had for heart disease in the future, women who had radiation therapy for breast cancer, chemotherapy are also risk factors. So we have a different set of risk factors in addition to the traditional risk factors associated with heart disease. And this is our gestational disorders, gestational hypertension, preeclampsia that has been associated with development of heart disease in women. Postpartum cardiomyopathy is a problem also that has been in terms of the heart. That's the development of heart failure during pregnancy or after pregnancy. And to finish, I want to show my last slide because be your own advocate. And I want to thank Myra Edwards in her testimonial. Unfortunately, when it comes to women presented to the emergency room or sometimes to primary care doctors, their symptoms are frequently ignored. And we present with not the traditional symptoms many times. So you need to ask questions, your medical history, know your numbers, and get a second or third opinion if you feel your symptoms are being ignored. And like Myra Edwards did in the emergency room, she said, you know what, I'm having yaw pain, and she realized her symptoms are getting worse, and she spoke. She didn't just sit there. So it's very important, and it's sad that at this time we still have to do that, but it's a reality. So I just want encourage women to be your own advocate. And thank you for inviting me to be here today.
Thank you, Dr. Hernandez, for the wealth of information. Thank you so much. Definitely my biggest takeaway is to be your own health advocate when it comes to our health. And now we will have Dr. Janet Dunn-Roman.
Good morning, everyone. Thank you so much for having me back again this year. It's a pleasure to be with you all. I hope you can hear me well. So I come to talk to you guys today about heart failure in the African-American woman. But I also just want to hone in more on the difference between my talk this year and last year will be honing in on preventative measures and why is heart failure getting worse in our younger Black women. So my first slide is about our clinical problem. Just quick overview because the presenters that came before me, Dr. Bullock, Dr. Morrison, and Dr. Hernandez did a fantastic job with a lot of the structural parts of the heart and things of that nature. So I'll gloss over that. But heart failure, just for those of you that are new to my presentation, it's a chronic debilitating disease. There's no cure for it. And so many of my patients don't know that there's no cure for their heart failure. The heart has one job. It's to pump the blood forward, enough blood to go through the body to meet the needs of the body. As if when you're walking fast, you need a little more oxygen. The blood is what's carrying that oxygen, and the heart is what's pumping it. Heart failure is so unpredictable. You can do everything right, take your medications, eat right, exercise, and still run into problems. And what it happens is You have periods of where everything's working well, and then periods of exacerbation. And this just happens and it goes back and forth. So our background, I just want to paint the picture. On the next slide here, I just talk about a bunch of numbers. And I do that so that you understand how big of a deal heart failure is and how big of a deal it is in our African-American women. There's over 7 million cases of heart failure in the US annually. And every year, we're getting upwards of 800,000 new cases diagnosed every year. The staggering number for me is that of that 7 million cases, 1 million folks are going to the hospital. That means your heart failure is so bad that you can't be at home and just take medications and treatments at home. You're so sick that 1 million folks are going to the hospital. Of those million, 25% are going back within 30 days. That's 250,000 people that are going into the hospital for heart failure and then being readmitted within 30 days. That's a lot of folks. And then, what makes the world go round? Money. We're spending billions of dollars, over $40 billion annually on heart failure associated costs. And that's billions with a B. That's a lot of money. So my next slide. What's happening in our Black women? Our Black women are developing heart failure double the rate of our white counterparts. We're getting heart failure prematurely under the age of 50. And I have a study that I just read actually 2 days ago for something else I was doing. And it's showing that Black women 35 to 54 years of age are having alarming rates of premature heart failure. We also had higher risk of developing heart failure, worsening heart failure, within 1.5 years. Why is all of this happening? So because of health disparities, because of genetics, because of environmental factors, what are the contributing factors? On my next slide, Black women were more vulnerable to social stressors. The literature says that some of us have, limited income, we have less education, and then again, just general health disparities. So this interesting article that I just read, it talks about how Black women, we juggle well. We are good at keeping 99 balls in the air. We always have more on our plates than others. And this dates back from slavery to present time. And I know Dr. Hernandez and Dr. Morrison touched on this, but pregnancy with no live births or 5 or more births in women, in Black women, makes you more susceptible to developing heart failure. So my next slide gives you a little of that visual of the heart and what's happening. So because my counterparts did a great job describing this, I'm just going to say in short, again, heart failure is all about the blood flow. The blood comes into the heart from the body. And when it's coming back to the body, comes into the right side. And then it goes, a lot of people don't know that the heart is directly connected to the lungs. So when the blood leaves the right side of the heart, it goes into the veins that lead to the lungs. And it goes into the lungs, picks up a little oxygen, then comes out on the other side, the left side of the heart. And that's where it is swirled around and goes out to the body to meet the body's demands. So that's just a visual of what should be happening. You got to understand normal, because depending on where your heart is broken or where it's failing, if it's on the right side, usually you see those symptoms in the body, like you have bloating in the stomach and the like. When the heart is broken or failing on the left side, if you send the blood in reverse, it's going into the lungs. These are the folks that are short of breath. And it's very, very challenging for me to explain that to my African-American patients. They'll say, I don't have a problem with my heart. I just can't breathe. And so that's where I have to go into this picture of explaining the heart and the lungs work together. So on my next slide, what causes the heart to fail? And again, all of the presenters before me honed in on this very well. One of the big things that causes heart failure is heart attacks. 30 years ago, if you had a heart attack, you generally, sadly, passed away. We didn't have all of the modern technology, the modern science that we have now, where we can get you to the cath lab and open up that blood vessel. So folks passed away at young ages from heart attacks. Hypertension is the #1 chronic disease that causes heart failure. Uncontrolled hypertension affects Black women disproportionately to other races. Anemia, arrhythmia, these are two things that we just talked about, are also other diseases that cause heart failure, and emotional stress can cause your heart to fail over time. So you don't wake up with heart failure the very next day when you have these things, but hypertension that is not taken care of can cause heart failure. So on my next slide, the slide says it all. Prevention is key. And this is what everyone else before me has been speaking about. What can we do? So the hypertension, the diabetes, the obesity, the high cholesterol or atherosclerosis, even sleep disorders. You know, we joke with our significant others and our partners about how bad they snore and the like. But that's a bad sign. That's a clue that something is wrong. It could just be something in your sinuses, or it could be something worse in your lungs that's causing sleep apnea or the like that can also damage your heart. Again, because the heart and lungs are connected. So treat our chronic conditions is the main thing that we can do. Once you develop heart failure, if you remember my opening statement, there is no cure for heart failure. So once you get it, you've got it. It's not going away. The best we can do is treat your symptoms and try to keep your symptoms at bay. But what we now know is that prevention is what we're striving for. So on my next slide, daily prevention. And again, Dr. Morrison talked a lot about this. These are the things she talks to her patients, which I love to hear my primary care providers talking to their patients about prevention. Eating that heart healthy diet, exercising most days of the week. If you're smoking, okay, I'm not gonna say anymore, don't, and then alcohol in moderation. So my next slide, let's just talk about this. What can we do for heart failure? First thing is medical management. These are all the different pills and medicines that we give you for your heart failure, right? And they're generally pretty vast because the blood runs throughout the body. A lot of things are happening. Your kidneys, when it senses not enough blood flow, your kidneys tend to hold on to fluid, and that makes you swell up. It makes you get fluid in your lungs. So you need a medicine to turn off that mechanism. You also have constriction. You have a systemic inflammatory response. So you need medication. And then when all of those responses don't work, your body gets nervous. It goes into fight or flight mode, and your heart rate goes faster and faster. So now you got this weak heart that is now beating too fast. So of course, we need to slow that down. So after medical management or medication management, the next thing we have is advanced therapies. And I have a slide coming after this that shows you a little more. But our advanced therapies, this is when your pills don't work anymore. We have sometimes sent patients home with IV medications. We sometimes look at mechanical devices for them. We also look at heart transplant. That is an option as well. And so these are our advanced therapies. Now, looking at my previous slide, you see the last house on the block is hospice. If a patient is not a candidate for these advanced therapies or does not choose to partake, there is no other option because there's no cure other than hospice, okay? So I showed you on the next slide, we can skip on over the devices. That's just a schematic of what some of the devices look like. So let's talk goals of care. So in addition to being a heart failure specialist, I'm also a hospice and palliative care provider. And the reason I got into hospice and palliative care, I am a critical care heart failure nurse born and bred. My experience has always been in the critical settings in the cardiac units. However, being in those settings, these heart failure patients were coming in time and time again into the hospitals. And I just, couldn't fathom what to do with these folks. So one day, a group of people came in, talked to one of my patients that comes in to the hospital quite often. And when they left, the family was all laughing and joking. This patient, in my eyes, is dying and not doing well. So I asked this group, I said, what team are you? And they were the palliative care team. And I was a novice nurse at that time, didn't know anything about palliative care. So from that point forward, I saw the effects of palliative care firsthand. So throughout my career, I had always been the palliative care champion on my unit wherever I worked until the latter part. I just got good at having these conversations with patients. Like, where do you go from here? So goals of care, what are you talking about? You're having that one-on-one, that gut-wrenching talk with your patients, making sure that they understand, not doom and gloom, but if you understand what's happening with your body, you get to participate in your care. You get to decide what care you want and what you don't want. A lot of times patients accept devices, accept heart transplant. Heart transplant, you're trading one disease for the other. You don't have heart failure, but now you have the care of someone else's.
One moment, lady.
I got disconnected for some reason. I'm still here. Can you guys hear me?
Yes, we can.
Okay. So again, if they're not a candidate, but this is the time that you want to talk to them about their goals. It's not end of life. This is when you're diagnosed with heart failure. The earlier, the better. And it's also better, the conversation had from the primary care providers. If you call me and I'm a consult, you may have never met me before, but the conversation of what's available and what does the patient want. So next slide, please. So the palliative care team, it's a group of providers. We have social workers, we have dietitians, chaplains, psychologists. It is an interdisciplinary group. We cover all aspects of care with the patient. So, what's stressing you out? If you have a bad heart failure, what is stressing you about that? Is it, that you can't work as much as you used to? You might be the primary partner that had the health insurance. And with you not being able to work, you're stressed out about who's going to cover your health care for your family and children. So things of those natures. Social work helps with that. Dietitians help with the diet. So it's not about preparing to die. It's about how do you want to live and making that plan of care. Next slide, please. So I love this picture. I used this slide last year, but ask questions. Keep asking questions until you understand. A lot of time providers will come into the room and give you your diagnosis and tell you what treatment you're getting, and you have no idea what it is. Slow them down, ask them again, and keep asking until you get the proper care. Get second opinions. I heard, I believe it was Dr. Hernandez say, ask for a third opinion. It doesn't feel right, it isn't right. So thank you so much for having me back again this year. I think that's my last slide.
Thank you so much, Dr. Roman.
Okay, yes, thank you, Dr. Dunn-Roman, for that wonderful information. And now we will have our last testimonial by Ms. Denise Smith, who's actually a charter member of the National Coalition of 100 Black Women in Central New Jersey. And she will share her story on how she's living with heart disease. Thank you, Sister Denise.
Thank you. Good morning, everyone. It was such a pleasure to be invited today by Damali Stansbury and the National Coalition of 100 Black Women, Philadelphia. I am happy to be here. Like the other women and the doctors mentioned, know your numbers. My story is a little dramatic, and I want to just, make it a little upbeat what happened to me, because I just was, and I am, an ordinary person driving down the New Jersey Turnpike in 2019, and I could not catch my breath. So I thought, oh, what's going on? I couldn't catch my breath as I'm driving, I'm saying, I'm remembering all the Netflix and all the ER TV shows. And I'm like, something is wrong. I don't want to pull to the side of the road because that means 9/11 have to find me. And that's going to take some time. So quick thinking, and I think intervention made me get off the turnpike, off at exit 5, ran into a Wawa, and I told the cashier, I can't breathe. And from that moment of quick thinking and telling her that I could not breathe, the next thing I knew, I was waking up in ICU, intubated, and it was a couple of days later. What happened is that I couldn't breathe, and my EF numbers, which is the ejection fraction numbers, which the range should be for normal people, 50 to 70, mine was less than 20. I didn't know it. No history of heart disease in my family. I lived my life. I may have got out of breath a few times, but thinking, I'm out of shape. I need to exercise. No thought whatsoever that is my heart. So when the doctors mention know your numbers, that is so key. Know your numbers. Have the conversation with your cardiologist or the beginning conversations with your primary care physician to say, hey, I know that there is something called ejection fraction. I want to get a baseline of those numbers. There's nothing wrong with having conversations about having an EKG or cardiac catheterization, because these things I didn't know. As I mentioned earlier, an ordinary person, no heart disease in my family, no thought of having a cardiologist in my life. I only had a primary healthcare provider. So having an ejection fraction next to 20% meant I needed a pacemaker. And all of this happened in my early 50s. I was about 52 years old. So when the doctors mentioned earlier, and they did such an excellent job and so much information on this call today about our Black women not knowing our numbers, not listening to our own bodies, can result in a situation that I found myself into. So I hope that I shared today, and maybe you can ask, and I challenge you, when you go back to your primary care physicians, to ask them about the EJ numbers that also is included with the diabetes and hypertension. Ask them about ejection fraction, which is normally called EF. I had no clue about it, but now as a survivor and as a pacemaker and having a pacemaker, I do know the questions to ask. But for those out there that don't know, I think the start is, what is my ejection fraction number? Thanks again for having me today.
Okay, thank you so much, Sister Denise, for your wonderful testimonial. And we're glad that you're doing well. And now we will turn the portion over. We have our Q&A section at this time, and I'll turn over the program to Dr. Culverson.
Thank you, panelists, to Dr. Bullock Palmer, Dr. Hernandez, Morrison, and Dr. Roman. You shared some wonderful, phenomenal, excellent tips that our attendees can definitely take away. We had a lot of fantastic questions to go through. I will begin with the first question. Obesity is a large risk for heart disease. How does the geriatric sleeve bypass help decrease the risk? And I'll pose that question to Dr. Hernandez.
Hello. Can you hear me?
Yes.
Okay. Yeah, this is a very good question. Actually, recently the American Heart Association stated that in patients who, try everything, diet, and they just cannot get their weight off, actually bariatric surgery is helpful because it can, the issue is that you can decrease the risk factors such as hypertension, specifically diabetes, and it will decrease the risk factors for heart disease. So if you try everything and you're properly evaluated, but you need to go to a good bariatric program, they normally do, most of the programs have patients go through a trial of good diet and trying to do everything before they go to surgery. But yes, if that's an option and you qualify and there's no other option, it will decrease the risk factors. And I want to add here, take the opportunity to mention, following this excellent testimony from Philip Denise, if you have a family history of heart disease, you can actually make an appointment, or you have multiple risk factors. We have cardiologists who specialize in prevention, or see a cardiologist just to get a evaluation, and you might not have to see them again. But there is an option. You don't have to wait until you have a diagnosed heart problem. You can just make an appointment to be evaluated and see for prevention.
Thank you, Dr. Hernandez. Absolutely great point. I have one other question for you. You were talking about the various arrhythmias, and often those arrhythmias are picked up by monitors. You mentioned that. How long should someone wear the monitor in order to identify some of those irregular rhythms? Sometimes people are told 30 days. Some people are told longer times. Is there a recommended time?
The recommended time is actually very individualized. I might see a patient in like 6-10 patients in one day, for example, that have a new palpit arrhythmia, and it's based on the frequency of the symptoms. If you're having the symptoms every day or every other day, 1 week monitor is because you're having them every day. But if you're having them every 5 weeks, 6 months, that's where the other types of monitors come in. So I find that it's totally useless to use a 24-hour or 48-hour monitor. I rarely use it because if you're having the symptoms every few weeks, it's a discussion with your physician, and that's where the physician's expertise comes in for your individualized history.
Thank you, Dr. Hernandez. Dr. Morrison, I have a combined question for you. How can we as patients become better advocates for our health? And what should we ask our primary care physician in terms of tests that we should have done to help with prevention?
Thank you so much, Dr. Coverson. I think it's important to, number one, make a decision to see your provider annually, because the provider-patient relationship is the benchmark for your overall health and wellness. And that relationship should be something that is intimate and individualized. And it's important for the provider to allow the patient to be vulnerable and to ask questions. I empower my patients to really advocate for themselves, because I am the primary care person. So a personal history of mine, just to back up, is I had a maternal grandmother who had colon cancer and passed away at the age of 51. And this is in the 80s. There was no colonoscopies and intense screenings and things like that. Hence, my first colonoscopy was at the age of 35 because I knew I had a strong family history. And I've received a colonoscopy for every 5 years I'm going, but I had to advocate for that. I had to, empower myself by being educated and telling my primary care provider that I needed to go to see a GI doctor. So I think education is so important. And, I think about those patients who are not in the medical field. We have to really fight for them to get the services that they need. And the resources are plentiful, but the searchers are few. So just really helping them to, ask the questions. And I do a lot of role playing, even in my primary care visits. I don't do the 7-minute door to door. And, part of taking a lot of my positions was I need to spend time with my patients and I need to I would write down things for them to ask. And really taking ownership of their health. I did have a patient recently who did go through gastric bypass surgery. So now they come to me for anemia panels, making sure they're hydrated, staying hydrated, decreasing infection risk, and just really educating them on that piece. Because when all else fails, like Dr. Hernandez shared, that is something that is going to increase your quality of life and help to rid yourself of diabetes and heart disease and hypertension. But the flip side is we have to make sure that we're not depleting our energy stores and our natural nutrients and our hydration statuses. You're on mute, Dr. Coverson. I'm sorry.
I'm sorry. Thank you for that answer, Dr. Morrison. We are at 11:40. I see that all participants are still engaged. So I have 2 other questions and then we'll move on to talking about legislative things to keep in mind and then our wine raffle. So the next question, and I'll pose this to all 3 panelists. How often should you see your cardiologist for women over 40? And are there any special tests that you should advocate for yourself?
Let me start. I think the key is if you are, I assume this is for someone who's healthy. If you're healthy, the key is I would start, if you're healthy, I would start with a primary care doctor. But if you have the sense that, not all primary care doctors are as excellent as Dr. Morrison, unfortunately, is a fact. So if you feel that your physician is not hearing you and you ask for evaluation, even if you're healthy, you can do a visit to get the initial preventive care. And that would include, in addition to checking the blood sugar, blood pressure, we order a fasting baseline lipid profile to know if you have high cholesterol or not. You may not realize that you have high cholesterol already. And I just want to mention, of course, the electrocardiogram. But I want to take this opportunity to mention one test you should all be aware. If you have risk factors for heart disease, and specifically if you have a history of family history of heart disease or cardiac a heart attack in their 40s or 50s, premature coronary disease in your family, there is a test that we're ordering, which is called, it's a plain CAT scan. It's called CT heart calcium score. And actually many primary care physicians order it if they have patients with risk factors, and very helpful for family history of heart disease early, because that could be genetic. And what that does, it's a plain CAT scan, no IV. I had it done for myself. You just lie down, it's like 15 minutes. but it checks for calcium buildup in the arteries of the heart, the coronary arteries. And that doesn't mean you have a blockage. It means that the process is starting. So that's the key for prevention. Our cardiologists order it regularly. I do, even in my patients that come from arrhythmias, they have a lot of risk factors, they don't have chest pain or anything, I order it. And that if you have zero calcifications, that good news, it means that's a test you want to have a zero. Means that you are okay probably for the next 10 years. You continue to modify your risk factors and lifestyle. But I have patients that they have significant calcium buildup. So we need to be more aggressive to prevent a heart attack. So these patients are started with statins early on. So that's one test that you might discuss with your primary care doctor or cardiologist if you're a candidate. And that takes an early look. And we didn't have those tools. Our parents, grandparents didn't have that option.
Thank you, Dr. Hernandez. So before I move on to the next question, because of some of the things that you mentioned, another guest asked whether or not there are any vitamins or holistic things that you can do or take in order to decrease the risk of heart disease.
I have to tell you that the data on supplements for heart disease has shown that they're not helpful. They might not be harmful, but I hate to see people spending a lot of money on supplements that they should probably spend on fresh, healthy food instead. The one supplement worth mentioning is the omega. The omega-3 fatty acids decrease triglycerides if you have a high triglyceride, decrease blood pressure, is anti-inflammatory, and there is some data that if you have risk factors, then it may help, and especially if you don't eat fish, that could be a supplement that you could use, but it's usually in patients who already has some risk factors, not just if you're healthy and you've been checked and you're fine, there's no need to spend money on that. What the American Heart Association recommends is eating fish twice a week. And that has really healthy omegas rather than spending money on vitamins. I don't know if you have any suggestions, Dr. Morrison, or the other?
No, I totally agree. That question is so common because people think that there's a vitamin or a pill, and like you said, spending that money on nutritious foods and, green leafy vegetables, beans, and fish is more important.
All right,
I'd like to just add,
Oh, sure.
I'm sorry. I was just going to add one comment to that. If you're eating a well-balanced diet, most of the supplements that you would buy, you're getting it in those fresh fruits, fresh vegetables, fresh fish, fresh meats. So you can, again, appropriate your money on the better foods.
Perfect timing, Dr. Dunn. Roman, I have a question for you. So when should you start to have the goals of care conversation as a heart failure patient?
So I like to have, the earlier you have the conversation, the better. Now, and that's patient specific. So if you have someone young that just came into your office and just like one of our testimonies, that young lady didn't know that she had heart failure. So maybe that's not the day you bombard her with everything because she has to get her health together first. But once after diagnosis, as soon as you can start the conversation, and it's not a one and done. You start by asking, what do you think about all this? What are your questions about this? What has the cardiologist been telling you? Ideally, this conversation should start with the primary care provider, just to get the understanding. And then from there, what treatments are available? So that could be a combination of primary care starting it, but then the cardiologist. Once they review all of the treatments that are available, you want to give the patient a chance to reflect. You don't want to be rolling them into the operating room to get a LVAD or one of those permanent pumps, and the patient is not clear on exactly what's happening. So you want to have those goals of care as early as possible, again, without overwhelming the patient that's brand new to the diagnosis, but just start sprinkling it in there on the visits.
Again, thank you so much for all of the panelists. We could go on for another hour with the wealth of information that was shared. We'll move on in our program with talking about the call of action. So please join us with the National Coalition of 100 Black Women in supporting legislation that protect the health of all present and future Pennsylvanians. House Bill 1886 is sponsored by State Rep Donna Bullock in Legislative District 195th. It makes a commitment to provide health equity, which is incredibly important for the minority patient, and act providing for the Office of Health Equity, establishing the Office of Health Equity Advisory Committee, and specifically, it includes disparities related to exactly what our topic was today, including coronary heart disease and stroke. And now, thanking again our testimonials and our speakers for this evening, we will move on to the wine raffle. I'll pass the mic over to our fundraiser chair.
Hi, good morning, everybody. All right, so I'm going to share my screen now. All right, so I just want to thank everyone for purchasing a Melanin and Quart wine basket raffle. Our basket consists of 6 wine bottles and a plethora of wine accessories, which I'm sure if you win, you will love. And this fundraiser is definitely working with the health committee, so it helps the programming of that committee. And we will connect with the winner this weekend, and may the odds ever be in your favor, and we'll start the raffle now. Okay, so Dina Bates, you are our first winner. Congrats. All right, our second winner will be Gerald Ray. You are our second winner. All right, our last winner of the day, who will it be? And Miss Aaliyah Barnhill is our last winner. Thank you everyone for supporting this fundraiser. Thank you.
Thank you. We will now have final remarks by Madam President.
All right, so I didn't win, but it's okay. It is okay. We are all winners today. We are winners by the wealth of information. I've been seeing the chat, been getting private messages to all of our doctors and testimonial givers. Thank you, thank you, thank you. You could be anywhere in the world, but you chose to be here with us, providing us with some great information. Just a personal note, that was my question about the age 40 and over. How often should I be seeing my cardiologist? For me, literally, it's been a few years. I was born with a heart murmur, a regular heartbeat, had heart surgery years and years ago. Members, you may not have known that. I can consider myself a healthy person, but you never know. So I learned so much more today than what I knew even just 365 days ago. And let's be real, during this pandemic time, a lot of us, our lifestyles have really taken a turn, right? And we feel like we're doing a bit more, but we know we can do more. And so today was part of that, doing more, learning more. Please don't keep this information to yourself. You're going to receive an email with the resources that are before you on the screen, as well as the survey link. And we will make sure that we give you the information to each of the panelists so you can talk more with them. This is just a tidbit of what you can learn today. Again, make sure you are talking about your heart health and doing more about it. Again, follow us at any of our social media platforms, our website that's before you as well. And make sure that you are, again, sharing the information with others. How many of you went to a restaurant last night? You might have had a little drink somewhere else. You found a new place to consign or shop, getting consignment options. You were so quick to let people know about that. Let's let folks know about what we learned today. And then let's also do that call to action. You'll learn more about that. You again have been here with the National Coalition of 100 Black Women Incorporated Pennsylvania chapter for our Heart Healthy Conversation. And we are so thankful that you chose to be here with us today. Have a great rest of the day. Maybe going out, do a couple miles, walk a little, start with that. If you are walking to Chick-fil-A to get that milkshake, do a couple more laps while they're doing it or different things like that. All in moderation is what we learned about it, and to really make sure that we are knowing our numbers. Thank you again. Have a great day.